everybody, and welcome to Chapter 9. In Chapter 9, we are going to be covering sexual and identity disorders. So we need to start up with a topic about what is normal sexual behavior versus what is abnormal sexual behavior. There's some very gray area here. It largely depends on where the social view is at the time. Over time, we define things as acceptable or unacceptable sexually. Now, many things are fine that would not have been okay 50 years ago or 100 years ago. So here, this is an example of when we get into that, what are our cultural definitions of acceptable versus unacceptable. The current norm for sexual behavior allows for a lot of variety. Anything goes pretty much, so long as it's consenting adults, and everybody's, like I said, over 18, and everybody's participating and consenting. However, if your sexual proclivities cause impairment in functioning, and when I say functioning, I mean the successful engagement in a relationship, the ability to engage in sexual consensual relations, etc., then it becomes an issue or it becomes a problem. I want to define sexual dysfunction, which is an inability to sexually perform or function to the point of an orgasm. These are three separate categories that we're going to focus on. So first is sexual dysfunction. Second is the paraphiliac disorders. This gets its own category in the DSM-5. This used to be lumped in as one and the same with sexual dysfunction, but it's not always dysfunctional, which is why they've created their own category. This is defined as sexual arousal to inappropriate, frequently inanimate objects, which or people, and in this case it could be children, is what we're talking about as pedophilia. But paraphilia is not always a problem. We'll get to that in a bit. Okay, it's always a problem with children, obviously, but we'll get to that in a bit. And then finally, there's the third category, which is gender dysphoria, which also used to be categorized as a sexual dysfunction, but we have redefined in the DSM-5 that it's not a sexual dysfunction per se. It's when somebody experiences distress or dissatisfaction with the gender that they are assigned at birth. In short, they don't feel like what's inside and their cognitive image of themselves matches the gender that they were born into or that they were assigned at birth. So let's start with sexual disorders. Okay, first is female sexual interest or female arousal disorder. This is the recurrent inability to attain or maintain adequate lubrication and sexual excitement response to the point of completion of the sexual activity. This often results in a deficit in sexual interest, desire, and arousal. There's male hypoactive sexual desire disorder. This is sort of the male version. The biology is different, but it's kind of the same thing. Is that the man has little or no sexual interest. Are these issues a problem if you're okay with it? Not really. It doesn't become a disorder. What makes it a disorder is the presence of those symptoms plus the experience of distress, that you are bothered, that you have no sexual interest, or that it's making your intimate relationships, marriage, whatever, dysfunctional because the other partner feels that there's no sex life, there's no intimacy. So if you're a single person and you're okay with not having sex, it doesn't really rise to the level of diagnosable criteria. But if it causes you distress, then it does. Okay, sexual arousal disorders. Erectile disorder, which is more commonly referred to as erectile dysfunction. This is an inability for a man to acquire or to maintain an erection throughout intercourse. Sexual desire is present, it's not a problem. The man has a sexual hunger. It is the physicality that's the issue. The inability, some men can get an erection, but in the middle of intercourse, it goes away, which means intercourse ends prematurely, or they just can't get an erection in order to even initiate intercourse. This disorder becomes increasingly common with age, and it's more difficult to manage than female arousal disinterest. It's much more difficult to manage. No intercourse can happen when a man is not aroused. When a female is not aroused, there are other things that you can use as alternatives, right? You can use synthetic lubricants and so forth to get intercourse going. But if a man cannot achieve or maintain an erection, sexuality is not possible. Next is orgasm disorders. This is more common in women than men. Okay, first is delayed ejaculation. This is in the male. It's when a male can only achieve an orgasm with difficulty. It takes an excessive amount of time, an abnormal amount of time. That is delayed ejaculation. The second is female orgasmic disorder, which is a delay or absence in orgasm in women despite having a normal sexual excitement response. This is also referred to as an inhibited orgasm. So she can become sexually aroused, she has a sexual hunger and a sexual desire, but she has an inability to climax or to achieve the point of orgasm. Next is a male disorder, which is called a retrograde ejaculation, and this is when the ejaculate travels backwards instead of exiting the body at the point of orgasm. It re-enters the bladder. It goes back up the penis into the bladder rather than exiting the body when orgasm occurs. Finally, there's premature ejaculation. This is ejaculation before the person who is engaging in sex desires to do so, often with minimal stimulation. A good rule of thumb to identify this is within 60 seconds of intercourse beginning. If the male is ejaculating, he is suffering from premature ejaculation. This is a fairly common disorder for men to experience at some point in their lives. 21% of all men report having had this issue. And it also has, it's an issue of age. It's more common in men who are younger and who have less sexual experience. With more time, more practice, more experience, there comes more control. Let's move on to sexual pain disorders. The first one is genitopelvic pain, or it's also called penetration disorder. This is a sexual disorder of women who experience pain during penetration. It may be the result of another disorder, which we're going to talk about in a second, called vaginismus. But it's essentially the intercourse is really painful to the point that you don't want to have it, right? Following, or it could be as a result of the following, which is vaginismus, which is involuntary reoccurring muscle spasms in the outer third layer of the vagina that interferes with sexual intercourse. So there's so many spasms that you literally can't be penetrated, and if you can be, it's very, very painful. Women who suffer from this describe it as a ripping, a burning, or a tearing sensation, which sounds pretty terrible. Fortunately, this is relatively uncommon, as it only happens to about 6% of women. How do we assess sexual behavior, right? This is something that's open to a lot of interpretation. So how do we assess if there's a physical problem? How do we assess if there's an emotional problem, a psychological problem? How do we do that? So some of the methods that are used starts with the first one, which is an interview. The interview usually is coupled with a questionnaire that has predetermined questions looking to identify or not identify what problems are present. But it also allows for like fluidity. You can deviate from the questionnaire and ask more questions, delve into more areas. The second is a thorough physical medical examination. We want to rule out any physical problems causing inhibition in sexuality. So there's a lot of different medical issues that can cause people to lose sexual desire, to lose sexual function, to lose sexual response. And so that's part of the assessment process, is making sure it's not actually a physical issue. And if it is, then we address it as a physical issue. Finally is psychophysiological assessment, and this is an individual's physiological arousal will be measured to see if he or she is sexually responsive. So there are different mechanisms of measuring, but for both men and women, they will be presented with some sort of erotica or pornography in some capacity. There are actual measurements attached to their genitalia to see, is there a response or is there no response, which helps us to identify, is there a physical problem, is this an emotional problem, is this a psychological issue that you're having. If your body's responding, then we know it's not a physical problem. So that's really helpful in pinpointing what the issue may be. So let's talk about causes and treatments of sexual disorders. Like I said, we just talked about biological and health problems. If your body's not healthy, sex is going to be harder, period, end of story. You want to be in good shape, right? If for no other reason than to be healthy, and to have sex, right? You need to be healthy. If your body isn't functioning correctly, this interferes with sexual response. So for example, cardiovascular diseases interfere with, or can be the cause frequently of erectile disorder. Chronic illness can interfere with sexual response and sexual desire. Medications, if you are treating illness with consistent prescription medications, there are many, many, many prescription medications who have side effects that interfere with sexual desire and sexual response, sexual ability. And finally, of course, the use of drugs and alcohol, illegal drugs or prescription drugs and alcohol, disrupt the natural, normal sexual response and function. So all of these things are biological issues that we want to identify and be able to either rule out or say this is what's causing it. So that's one of many causes. Psychological contributions, this is a really, really big issue for people in general of both genders. This just comes down to performance anxiety, and this is a psychological issue. Are you nervous? Are you insecure about yourself physically or sexually? Are you insecure about your experience? Are you so worried about what your partner is going to think that you can't relax and enjoy yourself? Because if you can't, that's going to interfere with the way your body responds. Just like we've talked about stress and anxiety impacting us in other ways, it also impacts us in a sexual capacity. Ultimately, when people have psychological issues or performance anxiety, that's what gets in the way. Which whenever I teach this, I've always argued that our most important sexual organ is up here. It's our brain, because that can shut everything down. If people are nervous or uncomfortable, it's important that people are comfortable, confident, relaxed. Otherwise, sexuality can't occur in a natural, healthy function. There's also cultural influences. So some people are raised from a very young age, whether it's just their parents' perspective, whether it's a religious perspective, or what have you, that sexuality is wrong, sexuality is sinful, sexuality is dirty. And if that's the template or the model that you were raised with to understanding sexuality, it's going to impact and interfere with your sexual function. Sexuality is a normal part of human biological function. It's something that human beings do. It's a primary need. Sexual response is going to happen reflexively, automatically. There's nothing wrong with it. But there are many people who are raised with the idea that there's something inherently wrong with these reflexive responses that your body engages in, which causes shame, it causes guilt, and all of that causes interference in being able to sexually function successfully. Treatment. There's many different ways of treating different disorders. It depends on what the disorder is. But one of the biggest ways to treat any kind of sexual disorder or sexual dysfunction is education. Sitting somebody down and explaining, okay, this is what's going on with your body, or this is what's going on with your mind. Identifying, kind of like when we did the chapter on stress, identifying and being able to recognize what's causing it helps you to become more aware of it. To understand it better might lessen the anxiety, right? Sometimes literally, and this is an odd thought in the day of the internet, but sometimes people literally don't know what to do and they need instruction, and that's okay. You guys are at a massive advantage in this generation. You can Google anything and everything. In my generation and all the generations before, there was no such thing as Google. You figured it out as you went along. But there are still people who struggle and they don't quite know what they should be doing in terms of mechanics and logistics, and you can get counseling for that, which can help. Especially, and this is very common among young people who are sexually inexperienced or sexually starting out. There's a lot of mystery that surrounds sexuality simply because in our culture we don't tend to have frank discussions about sexuality and sexual exchanges, which is bizarre. It's a bizarre dichotomy because our media and our entertainment is so full of sexuality, but we as a culture have a hard time just having a really frank discussion about logistics. Another thing is sex therapy. There are individuals or couples that can go and seek out a sex therapist. You can go to somebody who is trained specifically in sexual disorders, sexual dysfunctions, and is trained specifically at focusing on helping couples get through, or individuals get through their sexual problems to navigate their sexual lives successfully and in a healthy, satisfying capacity. Medication, boy, was this a game changer. This is such a game changer for therapy in general. You're probably all aware of Viagra, which recently just went generic. This is the first time it's been generic. It was developed for something else entirely, but we found out that it promotes erections, and it became a treatment for erectile dysfunction or erectile disorder. And it was a game changer because prior to the development of Viagra, as men aged, if they got erectile disorder, that's it, game over, right? There's no more sex in the relationship. So if you're married to somebody and your husband gets erectile disorder, there's a lot of decisions to be made, right? You may never have sex again, either one of you, right? If you stay true to your vows and stay within the marriage. So you're faced with, do I lead a life of, unchosen celibacy, sort of forced celibacy, or do I cheat on my partner? Do I cheat on my spouse because I am a sexual being and I want to have sexual relationships? This was a huge thing for married couples in our culture in general because there was no way to treat erectile dysfunction. And everybody who came through this had to make this call and make this decision about, do we divorce? Do I stay with him because I love him but I have sex with other people, or do I choose to never have sex again to be respectful of our marriage? Created a lot of issues in relationships. And now it's all solved with a pill, right? Which is kind of amazing. Those conflicts are largely gone. because we simply have a pill that fixes the problem. If only everything in life were that simple, right? Other medications, for erectile disorder, there are injection of substances into the penis that can create an erection or it can spark or provoke an erection. There's surgery where implants can be placed in the penis. That's a permanent item that stays in there, and it's always sort of semi-erect, but you can like face it different directions, so it's not always a problem. There's vacuum therapy where there's essentially a vacuum that's placed on the tip of the penis, and it suctions, which results blood flow into the penis, and then you would place a ring at the base of the penis to stop the blood from going back into the body, stays in the penis, which keeps it erect for a sexual experience. So there's a lot of different ways to go about it. However, Viagra seems to be the easiest, but not everybody responds to it. Not every male responds to it. There's also injections where a man can inject what we call vasodilating drugs directly into the penis, and that vasodilation is supposed to increase the blood flow to obtain and maintain the erection. However, the injection process is painful, so this isn't a popular one. There's also prostheses, which I've told you about, which are the surgical implants. And those are largely the treatments that we have. Unfortunately, we haven't been able to develop a treatment for women that is as simple as Viagra, that just, taking a pill and creating sexual arousal. We're not there yet, although there's plenty of research being done on that to address the same issue in their female counterparts, but we're not there yet. I want to move on to other sexual disorders, the paraphilia disorders. Paraphilia disorders, like I said, it's when you have a sexual arousal or response to an inappropriate item or person. Now, in the case of an inappropriate person, we're always talking about children, children or non-willing participants, which makes that always a problem, a serious problem. It's breaking the law. It's horrendous. But with the rest of the paraphiliac disorders, it's only a problem if it interferes in your intimate relationships, or if you can only, if your partner's unwilling or unaccepting of your paraphilia. So let's get into some examples. But keep that in mind as I tell you each example, that it's not a formal disorder unless it causes distress. Without distress, it's just what it is. If you're okay with it, if your partner's okay with it, it's not a problem, it's not a disorder. However, if it causes you distress because you feel wrong about sexual arousal at this inanimate object, or if it causes your partner distress, or if you have a string of relationships that have ended because people just can't make their peace with your sexual proclivities, then it becomes a disorder. It inhibits your functioning. So the first is called frauderistic disorder, also referred to as frauderism, and this is when sexual gratification is gained by rubbing up against unwilling participants. Now this one's kind of the exception because a willing participant doesn't quite produce the sexual arousal. It has to be somebody who is unaware of what's going on, becomes shocked in the middle of the process. People who are frauderists engage in doing this, it's a public activity. They like crowded locations like concerts and subways, elevators, escalators, where it's not immediately obvious. You're going to be bumping into people. It's just the nature of where you are. So it's not immediately obvious that somebody is engaging in a sexual misbehavior with you unwillingly. But eventually it becomes very obvious because it's essentially just dry humping a stranger. But they like crowds and crowded locations. Fetishistic disorder. This is actually far more common than you would think, and it has a huge range of fetishes that people can be aroused by. So this is long-term, reoccurring sexual arousal, including fantasies and sexual behavior that involves non-living or unusual objects. So we're talking anything from shoes to hair to fingernails to women's lingerie, you name it. I've heard of, in rare instances, people getting sexual arousal over automobiles. There are so many fetishes out there. They come in so many shapes and sizes, right? Piercings, tattoos, mannequins, right? The mannequin one kind of freaks me out. Mannequins in general freak me out. But there's so many different fetishes out there. It takes a lot of different shapes and forms. And if it's something that doesn't upset you, that this is what I'm sexually aroused by, not a problem. If it doesn't upset your partner, not a problem. Shoe fetishes, very common, right? And a lot of women are okay with their male partner having a shoe fetish. It's not a big deal. I think you're going to have a harder time finding women that are okay with a mannequin fetish. So it all comes down to with this, what is this a disorder or is this not a disorder? Is it inhibiting regular function in your life? Next is voyeuristic disorder, and this is when sexual arousal is achieved from watching someone undress in a state of nudity and they are unaware of being watched. Largely, again, there's that element of you don't know I'm watching you, that's what makes it even more exciting. But many voyeurs also partake in consensual voyeurism, right, where people are well aware that they're being watched, whether they're being watched getting undressed or when people are, there are couples where one partner will go and engage in a sexual relationship with a stranger and say to that stranger, keep the blinds open, my husband's watching, so that people are aware, so that they are consensual participants. So it's not always completely masked in secrecy, but it absolutely can be. Next is exhibitionist disorder, which is sort of the yin to the yang of voyeuristic disorder. This is sexual gratification that's obtained by exposing genitals to other or by engaging in sexual acts in public. With this, we're talking our people who are streakers, your stereotypical, that sort of archetypal flasher guy that comes up in the trench coat and he flashes, he's completely naked and he runs away. What he is actually gaining from that sexually is your reaction of surprise is what he finds sexual arousing. I know it's really hard to not be surprised when somebody would do that, but if you're ever in that situation and you can try and control your reaction and not show shock or embarrassment or, surprise of any kind, it loses the reinforcement for the person to do it. There are also people who like engaging in sexual exchanges with other people in public because of the fear of getting caught. It's exciting, and the excitement is arousal. So that's also part of exhibitionistic disorder. Next is transvestic disorder. This is most common among males. Females can partake, but it's just much more common among males than females. And this is sexual arousal that is gained by wearing clothing from the opposite gender. So given that this is a male-dominated disorder, this is sexual arousal that's obtained when men put on women's clothing, women's lingerie, women's stockings, etc. Next is sexual sadism, which is sexual arousal as a result of inflicting pain or humiliation in other people. So it's suffering of some kind, be it physical or emotional humiliation and suffering. The yin to sadism's yang is sexual masochism. This is sexual arousal obtained through the experience of receiving physical pain or receiving humiliation. So never a problem if you can get a sadist and a masochist in a relation together. It's not a disorder, right? They're both consensual, adult, willing participants who are meeting each other's needs. They just happen to fit together sexually. However, this becomes a disorder, it becomes a problem when you have a sexual sadist with somebody who is not a masochist, right? People who have no desire to be physically harmed during a sexual exchange, which means either the sexual sadist is forcing people to do something or incorporating something they're not comfortable with, or they can't obtain sexual arousal and cannot sexually function in just a regular non-violent sexual exchange, which obviously is going to inhibit relationships. Same thing with masochism. Some people cannot obtain sexual arousal or gratification without having pain inflicted upon them, but not everybody's comfortable inflicting pain in the middle of sex. There's an entire population of women out there that enjoy being strangled when they reach the point of orgasm. There's a whole lot of men out there who are not comfortable doing that, right? It interrupts the sexual exchange. It undermines the sexual exchange when you don't have two participants that engage in both masochism and sadism. If you've got just one and your other partner just doesn't partake, it becomes a problem. So not a disorder if you can find willing participants. Otherwise, it becomes inhibitory. So I want to talk about paraphilias versus the paraphiliac disorder. So like I said, this is a question of partnership and interference, which we've talked about at some length. If your partner is not bothered by any of these, then go ahead and partake. It's not a disorder. There's no interruption in sexuality. There's no interruption in intimacy. There's no interruption in the relationship. It's not a problem. But let's say you can't find partners over the life course, or even just one, just in one relationship, that has to end because of your paraphilia. That's when it becomes a disorder. That's the distinction. If you have been with the last 6 people and they've all left because they're not comfortable with your paraphilia, that's when it becomes a formal disorder, that you can't engage in a non-paraphilia sexual exchange in an instance with a partner who would like you to. That's when it becomes a disorder. There's pedophilic disorder, which we are culturally well too aware of, unfortunately, and this is a sexual attraction from adults to children. The individual may be attracted to one or both genders. 90% of pedophiles are male. This is largely dominated, is a crime that's largely dominated by men. If the child victim and the abuser are genetically related, the terminology changes to incest. Frequently, incest is perpetrated from father to daughter as the daughter reaches puberty and begins to take on secondary sexual characteristics. And victims of incest are overwhelmingly female. So treatment for the paraphilia is, how do we change this for people who need it or want it to be changed? There's a couple of treatment approaches. The first is covert sensitization. This is a behavioral model that is used to reduce unwanted sexual behaviors by having clients imagine, they fantasize about the regular fantasy that they always have of a paraphilia. And at the point of orgasm or the point of climax, the therapist will say, introduce some other thought, some other sexually acceptable pro-social thought. Start replacing those thoughts and that physical experience paired together with a sexually pro-social, something that is social and acceptable. Do it time and time again, and you'll start pairing the pro-social sexual fantasy with the physical response, eliminating the desire for the paraphilia. So instead of masturbating to shoes, why don't you start, at the point of climax, start thinking about women, just women. Do this again and again and again, and eventually, hopefully, if it works, which doesn't always, your body will start to respond to the thought of the woman because you've paired it with your climax so frequently, rather than responding to an inanimate object. Oh, I'm so sorry. Everything I just told you was orgasmic reconditioning, not covert sensitization. So change that. Everything I just told you was orgasmic reconditioning. Covert sensitization is reducing aversive and negative sexual consequences in the behaviors by trying to imagine what a negative consequence. So you're having a fantasy, you're supposed to have a fantasy about that which you desire, whether it's shoes or cars or mannequins or whatever, and you're supposed to imagine in the middle of that fantasy, what if a negative consequence? What if you were masturbating to a mannequin and your wife walked in, or your kids walked in? Right? And what would your reaction be? What would their reaction be? How would that make you feel? Right? And if you imagine that negative consequence, it's supposed to sort of spoil the sexual gratification and excitement that is obtained by the fantasy. And if you do that repeatedly enough, you will sort of desensitize yourself to the paraphilia. Relapse prevention treatment. This is sort of taken from a drug addiction model. The individual is taught to recognize triggers and temptations early on. So when you feel yourself becoming aroused to your inanimate objects or whatever is inappropriate, you recognize it before you're fully aroused, before you're completely sexually aroused, and you exercise and institute self-control techniques, right? Things to disrupt the thought process, removing yourself from the environment where there are the triggers so that you're not being triggered, and etc. That's taken directly from drug addiction models, the idea of drugs being the trigger, alcohol being the trigger, so you get yourself out of a position where there are triggers before you're pot committed, essentially. Unfortunately, what we see is there is frequently modest to no success with pedophiles. We see more success with people treating the paraphilias. With pedophiles, it's incredibly hard to break, unfortunately, which is why we have such a high rate of childhood sexual victimization. It's also why we have such high recidivism rates among sexual offenders. There's not much we can do to deter the behavior once somebody starts down that path. Chemical castration is another option for treatment to interfere, and we've tried this with pedophiles, convicted pedophiles in some states. Chemical castration is simply taking drugs to inhibit the normal, healthy hormonal function within an individual so that they can no longer obtain an erection. So literally, you're taking pills or you're getting injections that are shutting down your reproductive system in a way that you can't have sexual arousal anymore. This can be used short term. It tends to be successful short term, but it's rarely successful long term. Ironically and strangely, what we see long term, especially with pedophiles, is that if I can no longer offend with my own body, they start offending with inanimate objects. So if the penis no longer works, there's no longer an erectile response, they will start offending against children, unfortunately, with inanimate objects, crowbars, hairbrushes, baseball bats, awfulness, which in many cases often causes more physical damage and trauma than using their body. So chemical castration is not really the best route to go. Okay, switching gears to gender dysphoria. So let's talk about what gender dysphoria is. This is psychological dissatisfaction and distress at one's biological gender. The focus is on the desire to live as a member of the opposite gender. excuse me, it's not a focus on sexuality. It's not a focus on changing sexuality from heterosexuality to homosexuality or bisexuality or anything like that. It's completely about gender identity. I was born into this body, but my mind doesn't match this body. I want to live as a member of the opposite gender. There's also gender nonconformity. This is when prepubescent children do not identify with their biological sex. They identify with the opposite gender, so they'll display behaviors and characteristics that are very common of an opposite gender. Frequently with gender nonconformity, kids outgrow it and find their spot in their gender, in the traditional gender roles that we've defined, but not so with gender dysphoria. That's something very different. That people who are born with this mental cognitive perception of one gender in the body of another gender suffer terribly, and it's not something that you can outgrow or get over, right? Something that they literally struggle with their whole lives. So there are a couple of things that can be done in terms of treatment, and the first is for people with gender dysphoria is psychological evaluation. Oh, excuse me, I'm sorry. Psychological evaluation to make sure that there are no other psychological mental illnesses going on that could be influencing the thought processes. Is this solely an issue of your gender identity, or could there be some other mental health issues going on? We want to rule that out. If we can rule out other mental health issues, what we do is we provide education to that individual, and we would say this is the process of transitioning from a male to a female or a female to a male. If this is something you want to do, if you think this would relieve your distress and your discomfort and your anxiety and your depression, understand this is what the process that you're going to have to go through. After they're educated, then there's hormonal control, where we start introducing them to the process of biology and physicality that we just educated them about. So taking hormones that would produce female secondary sexual characteristics in a male. For women transitioning to men, plastic surgery removing secondary characteristics such as your breasts. Finally, and the final step is sexual reassignment surgery. This is non-reversible though, so it is a very big deal. It's a very big decision. It's not something that should be taken at all lightly. You want to be absolutely positive because you can't reverse it. One of the things that therapists require of people pursuing sexual reassignment surgery is that you must live as the opposite gender for 1 to 2 years prior to getting the actual permanent surgery. Meaning that you must dress as, speak as, live as, if you're a male, you need to dress as, speak as a female with all of your friends, your family, in the workplace, in your life, so you get a taste for what it's like. So before it's made permanent and we can't fix anything or change anything, you want to make sure that you're pot committed, that I'm not going to change my mind. This is what feels right. Yes, there's going to be some feedback from the environment that may not be positive. I can handle that. It's still worth it to me to do this. Largely to make sure that you are positive before we do the reassignment surgery. It is permanent. It is not reversible. Largely, people who have sexual reassignment surgery are, express contentment and happiness with their decision many years later. However, there is still a population, typically less than 10%, who regret the decision, and there's nothing that can be done to fix that. So that's why we require the psych eval, the education, the hormonal treatment, and the living as the opposite gender, because the end point is something that you cannot change if you change your mind. And that's everything for chapter 9.